Good afternoon, good evening, and good morning, my dear colleagues around the world. We are about to begin our AsiaSafe webinar series on the diagnostic reference level, the DRL, and dose index registry, DIR, what, where, when, why, and how. Today, we are privileged to have a speaker, Associate Professor Dr. Samuel Brady from the United States. Before that, can we go back to the previous slide? Let me introduce President of the AOSR, who is with us, my co-moderator, Professor Noriyuki Tomiyama from Japan. So he'll be co-moderating with me. And I would like to acknowledge that this series will accumulate until May, June, was the brainchild of Dr. Tanya Ornorin Supaku from Thailand and United States. So she has been instrumental in initiating this webinar. So we'd like to acknowledge a great initiative and support. And today, Dr. Samuel Brady will speak with us on how to establish the national DRLs using dose management system, the DMS. Let me briefly introduce our speaker. Now, he's from Cincinnati Department of Radiology. He's a chief clinical medical physicist of Cincinnati Children's Hospital and also associate professor at the University of Cincinnati School of Medicine. As a fellow of the AAPM, and he had a lot of experience with the IAEA expert missions to Thailand to help them to start the DRL optimization and dose reduction. And he's been the international lecturer on the IAOC on imaging physics safety and working with the IEC, in particular 62B MT30 on computed tomography. And he has been very active in various national committees in the United States and various task groups. And you can see there's a lot of notable appointments. In particularly, he's a vice chair of the Image Gently Alliance. This is where I interacted with him earlier with the Image Gently, and he's with the ABR, the development of physics qualifying core section, and various chairs of the committee related to imaging physics and radiation safety. Okay, with that introduction, the next slide. We'll move to the next slide. You want to show the QR code? Yeah, we'll show this again. At the end of a talk, right, you want to get your certificate, so you scan that or it's an email given, so to get your certificate of attendance. So let us now welcome Dr. Samuel Brady.
Well, thank you. I appreciate that introduction. I'm going to now share my slides. Okay. Well, thank you. I really appreciate the opportunity to be with you this morning, this day, and to talk to you a little bit about establishing national DRLs. There's a lot of ways to do this, but we have been gifted with a lot of different technology. And one of those is a dose management system. And a lot of hospitals and clinics around the world have begun to invest in using these DMS softwares. And so I'm going to talk a little bit today about how we can use DMS softwares to aid us in establishing national DRLs. All right, before we start talking about dose and dose reduction, I want to always start by saying the number one goal that we have in radiology is to establishing acceptable image quality for the diagnostic task at hand. And after we've established that, then the second most important goal is how we utilize that radiation dose for imaging our patient populations. And so it's always important to
Sorry to interrupt. I think we don't see your screen.
It's not coming across. Okay, let me try sharing it again. Can you see my screen now?
Yes, it's coming back. Thank you.
Okay, sorry about that. All right, you didn't miss much. That was just my cover slide. All right, there we go. As I mentioned before, number one goal, we always want to make sure image quality is appropriate for the diagnostic task. We talk about dose and we talk about reducing dose because it's important to be good stewards of the amount of radiation we use when we image patients. We know that we use a little bit of radiation in radiology and the risks are very low, but we want to always maintain that low level of risk by using the lowest amount of radiation necessary to get the diagnostic task to achieve the diagnostic task at hand. And so DRLs are actually a very good tool in helping us to understand how the radiation dose levels we have at our hospital compare to a national standard. So the objective of a DRL is really to help us avoid delivering excess radiation that does not provide any additional clinical purpose. And we do this, of course, as I mentioned, by comparing what we do at our local hospital to a national standard. And so Dr. Canal, in her great talk a month ago, she talked about establishing DRLs and she talked about the dosimetric quantities that are involved in that. And she, in that talk, referenced this publication, ICRP publication 135. This is a great reference and is one that I will use throughout my talk today. And for those of you that are still familiarizing yourself with DRLs or would like to just have a nice refresher, I encourage you to return back. It's a freely available site publication online. So very quickly, it was just a quick review of what Dr. Canal taught us last month. DRLs. DRLs are established according to the ICRP 135 to set up a dose level that is at the third quartile or the 75th percentile of all national doses. And there's a second metric that we also use when we're helping to establish appropriate levels of dose in the nation, and that's called the Achievable Dose, or the AD. The achievable dose is the quantity defined at the median or the 50th percentile of all national doses. So we can use the DRL, the 75th percentile, and the achievable dose, or the 50th percentile, and we can use those as a way to benchmark how we perform at our institution compared to a national standard. And now DRL values are used to are only as good as the data that we collect locally from all of the different hospitals around the nation. And so to establish a DRL value, we need to collect locally sourced information. And we need to collect this data and we need to categorize it based on different types of examination, different equipment type, and of course, different patient demographics. I work at a children's hospital, so I'm partial to the idea that not all patients are the same size. But in fact, pediatrics, of course, have a variety of different sizes, and even adults have different sizes. So it's important that as we collect the dose data to establish DRLs, we also collect the patient demographic data. And it's important to be able to categorize these appropriately because not all exams are the same, and especially not all equipment are the same. Some people at one hospital may still use a 16-slice CT scanner, while others may be using new 320-slice CT scanners. And so the dosing is different, and it's not appropriate to compare a 16-slice CT scanner with, say, a 32-slice. So when we establish the DRLs, they're only as good as the data that we collect. And so what I'd like to do as a way to kind of direct us in this idea, this pursuit of establishing DRLs, is I found this paper. It came out of Europe, out of Spain, and this was a group that published their approach to establishing DRLs based on these 5 steps. And they did it specifically when they were establishing DRLs for interventional fluoroscopic systems. Though we're not going to talk specifically about any one modality, the steps are still the same, irrespective of the modality, and they will demonstrate a good visual way to approach establishing DRLs. So we're going to start off with the first step, which would be call for participation. This idea that at a national level, we need a national organization that will be able to organize and take charge of and ownership of the DRL process. And once they do that, they need to go out to the nation and they need to identify institutions that can help participate in the establishment of a DRL. So this is an example from the US. The ACR has its DIR system where a variety of different hospitals can submit their dose data for all the different exams they provide. And it's important that we don't only reach out to academic sites or to local community hospitals. We need to make sure we have a very good distribution across all of these hospitals because the patient demographics are going to probably be a little different depending on the type of clinic. Now, addition to that, here on the right, you see a map of the United States of America. All of these black dots represent sites in the US that are participating in sending data to the National Repository at the ACR. And you can see that they're spread across the nation. And one of the things the ACR did is they grouped the data. You can see these different colors. Each of these states are grouped into different colors, and that represents different regions. And that's because the people living on the west versus the east coast of our country, the north versus the south, they're different. There's subtle differences in the demographics. And so when we compare our local values, we do want to compare them to a national value, which is important, but it's also good to compare them to regional values, just so that you make sure you are comparing your doses to similar populations. But the important part here is that when you create the DRL, that you sample evenly or just from a distribution throughout the nation. So it's important to get a good distribution of types of hospitals and clinics and a distribution of your population throughout your country. The next thing you need to do is you need to identify common exam types. Now, it's kind of easy to do this. You can look at, say, the top 10, maybe 15 or 20 types of exams per imaging modality, and those can be the ones that you start establishing DRLs. We'll talk about them in a minute, the numbers of exams you should use to calculate your DRL, but you do need a sufficient number to get good statistics. And so it's always helpful to start with some of your highest imaged protocols. And then we need to establish the type of quantity or the metric in which we're going to collect. Now, Dr. Cannell talked quite a bit about this, and she did a great job describing the differences in these metrics. So I'm not going to go into that detail, but just as a reminder, every modality tends to have its own unique dose quantity. So for example, fluoroscopy, radiography, x-ray, mammography, you're going to want to collect something such as air kerma. Or in CT, you have the volume CTDI, DLP, SSTE. All of these are metrics that we can physically measure. And it's important that you have a metric that is measurable to calculate the DRL. One dose metric out there that is very common, you see this in literature all the time, and you see this oftentimes used inside your hospital as a way to report patient doses or exam doses, called the effective dose. The effective dose is not appropriate to use for DRLs because the effective dose cannot be measured. It's a metric that is calculated. It's a small distinction, but it's very important, and you'll understand why in a moment when I give another example. So we can only use the metrics that are measurable, and we do not use effective dose. And now, once we've identified the quantities per examination type that we're going to collect, we as an individual hospital, we need to collect the median dose value for those exams. Now, there are a variety of different ways statistically to calculate an average. So why do we choose the median? Well, as a quick example here, you can see two population distributions. One of them is a right skewed population, and the other one has a nice Gaussian normal distribution. And if I were to look at the mode average of these two distributions, this red line, vertical line, you can see that the mode for these two are different because the center value obviously is different in these two distributions. And the mean itself is also, the blue, vertical blue line is different. This right skewed distribution has a various high values, and that skews the mean towards a higher level. And as you can see, the median is most appropriate of the average of the statistics to calculate average because the green vertical line shown in these two distributions is actually identical. And it's because the median is less susceptible to the minimums and the maximums of a distribution. So we need to identify the exams, we need to identify the quantities, the dose quantities for those exams, and then we need to send the median dose values of those quantities. So that's the first step. The national organization has to organize. The second step is we need a call for participation. So now we're going to reach out to the local individuals, the local individual hospitals, excuse me. And they're going to then start looking in and collecting data for the predefined categories. As I mentioned, ICRP 135 is a great source for establishing DRLs. We learn from ICRP 135 that we need to calculate or collect a minimum of about 20 to 30 patients per exam type for fluoroscopy and about 50 patients for mammography. Now, in the ICRP 135, it doesn't define numbers for radiography or nukes and PET, but using that same idea of 20 to 30 is a safe number to collect. So we're going to go in and we're going to collect 20 to 30 the doses from exams from various different types of exams across all of these imaging modalities, 50, a few extra for mammography. And how do we do that? Well, there's a couple of ways to do that. And what I'm going to talk about for the majority of the rest of my talk is using this dose management software. It really streamlines the process of collecting, aggregating, and then transmitting this data. Now, not every hospital potentially in your nation has access to or has established these DMS softwares. And so there are other ways to do this. Historically, we have used national surveys using paper-based or electronic type Excel spreadsheets. And I'm going to give an example in a minute. It's not ideal to use this process because it requires a lot of manual labor to collect, manipulate, calculate the statistics, and then report it back to the individual institutions. So as an example, I just want to share this because not every hospital has access to DMS, but yet they can still participate on the National DRL initiative. Another paper from this group, they looked at establishing DRLs. This group came from Senegal. And they wanted to establish DRLs for radiography. And so they established this flow chart. They created a questionnaire with the questions necessary. They identified the most frequently performed exams. They established 9 exams, and they went and they petitioned. They petitioned each of the participants to collect 30 patients per exam. And then when they reached out, they asked for the individual hospitals to collect and identify various different technical parameters, such as the x-ray room and equipment being used, the patient demographics, the type of procedure, and very importantly, the output metrics for those exams. So the KV, the mass, the type of film, the film distance, etc. And this is a great example of how you can still participate even if you don't have a DMS. A DMS system would already automatically collect all of these dose metrics, and it already has it there in the software. But for those that don't have them, what you need to do is there's an extra step here where you need to take the known quantities, KV, mass, and you need to physically go to the machine and measure the dose output. So you can work with physicists or clinical engineers, and you can collect that data, and you can still then use that data to transmit or submit that to the national level. So using this process, it's a little bit more, it definitely more manual, but a little bit more time consuming, but it still enables everyone on a national level to participate. Now, I like that in this workflow, this group from Senegal added this extra step. A lot of people overlook this step, or at least we take it for granted. And it's important that before we sit down at the machine and we start measuring the air kerma or whatever dose metric that we need for DRL, that we make sure the machine itself is appropriately calibrated. So we do the proper testing. The physicists, the engineers, they do the proper testing for the quality control of that machine. It's important that we send good data to the national repository for calculations. If you have a machine that is systematically skewed too high or maybe too low, it doesn't help the national data collection and calculation for DRLs. Here are two examples I just found searching on the web, looking at various different publications. One comes from Korea out of a publication in 2023, where they established this Excel-based, paper-based spreadsheet where you can go in, you can fill out the various different levels of information. This is an example of a fairly complex survey. Lots of information pieces to collect, a lot of information per exam that needs to be collected. And on the right-hand side, this is an example of how the UK started out several decades ago. The survey is actually relatively simple, but it still provides the institution every opportunity to participate by collecting the necessary information. All right, so we can do this manually, and we want to give every hospital the opportunity to participate irrespective of their technological level. But in an ideal world, using this new software, the new technology such as dose monitoring software, we can streamline this process. And so going forward, I want to talk quite a bit about how to use the DMS. Now, first, I want to do a shout out to Dr. Sarah McKenney, a friend and colleague of mine. She gave a presentation through the IAEA, and this recording, I actually checked right before I came on, this recording is still live. You can go to the IAEA, here's the website right here, and you can click on this and you can watch her talk. And she gave a very thorough review of about 20 or so dose monitoring softwares that at the time, it's a couple years old, but at the time you could purchase. And the majority of those softwares are still available to purchase today. And so I highly recommend it if you are in the market for and still considering which type of software to purchase. Now, there are a lot of options out there to purchase, but there is still an option out there that is free. It's called OpenREM. Once again, before this presentation, I went online just to make sure it was still available and free. It provides the opportunity to do everything the purchased ones, the systems that cost money. You can do everything they do. Basically, they receive all the dose values from pretty much all the modalities. And so it's a great opportunity that if you don't have the funds or are not ready quite yet to buy a DMS system, you can start playing with that process using some open source software. All right, so once you have determined which dose monitoring software you're going to use, there's some questions that you need to consider when you've decided that you want to do this. There's a few questions you need to ask to decide which software would be best for establishing DRLs and for your hospital. A very important one, as I mentioned at the very beginning, is we do need to understand the patient demographics. And so it's great if the system will interface with the hospital informatics or the radiology informatics systems, the HIS and RIS system. If they can directly connect through HL7 messaging to the radiation monitoring, dose monitoring software, then you can get all of the demographics, age, size, BMI, all of that gets brought in and it gets married or linked to the imaging information that comes from the modality specifically. When you get patient demographics from the machine itself, you have to rely on the technologist entering the information accurately every time. And their technologists are wonderful, and they work really hard in environments much harder than mine sometimes as a physicist. But I know that there can always be mistakes here and there. And so it's always great to be able to interface directly with the HIS and the RIS. All right, the next question you need to ask is where do you get the dose information? So a very common approach is the system, the imaging modality itself, will directly send its dose reports to the dose repository system, the dose monitoring software. And that's great. And the other option out there of the systems you can purchase is once the imaging is complete and sent to PACS, then the dose monitoring software will actually go into PACS, scrape the information out, and bring it back to its database. Personally, at our hospital, we have a software called Gervais Dose and Care, and that's how it works. So when I buy a new piece of equipment, we set it up, and once it's sending to PACS, I know that all of that dosimetry data is already going to flow up, and I don't have to worry about hooking it up to two different places. There's pros and cons for both approaches. I really won't get into the details of it, but both of them do work. So you just need to understand how the dose data gets to the dose monitoring software. Can it be networked? So the question is, once you've got all of this information here, it's wonderful, it's beautiful, but you got to then use it. And so if you have the ability to network your dose monitoring softwares to multiple different, let's say you have one hospital that has multiple different satellites or different clinics, you want to be able to bring all that information in. And then additionally, it'd be wonderful if you can then network that to the national database. And so you can then just seamlessly send your data to the national level so that they can calculate the DRLs. And then you just need to make sure that the dose monitoring system or software can accept all imaging modalities that you intend to establish DRLs. So going back to that presentation from Dr. McKenney, when she reviewed it, and this is a couple of years old, but when she reviewed it, all of the softwares available at the time could receive and process CT dose data. But fewer, in her example, only 80% could actually process your various different fluoroscopy systems. And fewer than that, your x-ray machines. And then of course, PET, nuclear medicine, et cetera. And so it's important that if you want to set up national DRLs, for example, for nuclear medicine and PET, you need to make sure you pick a software that can process them, along with, of course, X-ray, fluoro, CT, mammo, et cetera. All right, the dose metric to be collected. This is also very important because, as I alluded to at the beginning, every modality has its unique way of describing radiation output. CT, of course, has the volume CTDI, DLP, SSDE, and that is physically different than the CAP or DAP that you would see on fluoroscopy and X-ray, which of course is different than, say, mean glandular dose in mammography. And so the software itself needs to be able to accept or collect the dosimetric quantities from each modality and needs to be able to recognize the differences of them so that it can collect them and store them. All right, now that you have your software, you've interfaced your modality, all the different imaging modalities. It is collecting all of this information. It's great, but it's a big pool of information. You need to now standardize the naming convention for all the different protocols you have so that you can start to make meaningful groups of information. Your hospital may call your routine brain a brain CT. Another hospital, even inside your own network, may call it brain with or without contrast or head CT, etc. They're all the same thing. They all are meant to perform the same scan, but they tend to have different naming conventions. So the idea here is we need to standardize that naming as much as we can. There's a couple of ways that we can approach this. I give you 3 examples. One example, we have in the US, we have something called the Current Procedural Terminology, or the CPT. It is it's a coding method was established so that the hospitals could bill or charge for their service. And so if I were to go into my local scanner, my hospital, and I get a head CT, however it's named on the CT scanner, the hospital will then bill under the CPT code for a head, usually without contrast. Now you can do that, and that's okay. Every nation's going to have its own unique way to set up its charging. And the naming convention can be very broad, anything like a head CT, or it can be very narrow in scope, head CT with or head CT without contrast, etc. So there are some positives. I would consider more negatives using the CPT charge codes as a way to standardize your naming convention. Another option out there is something called the Systemized Nomenclature of Medicine Clinical Terms, or SNOMED CT. In this case, the CT doesn't refer to the imaging modality, it refers to the terms clinical terms, or the words, I'm sorry, clinical terms. This is great. It's actually not used just for radiology. It's used across it can be used across the hospital to codify all the different terms in the medical complex. It's not just specific to, say, the US or say Europe. It's across 80 different countries. The downside to this is it does cost to be a participant to use it. But if you do elect to use SNOMED CT, it's a great way to interface your hospital or your radiology clinic, and they help you sort out and standardize the naming convention. Finally, the other option I would suggest is something called the RADLEX playbook. A couple of years ago, there were actually two different groups that were trying to standardize radiology nomenclature. One was called the LOINC, or LOINC, and the other one's called the RADLEX. In 2021, luckily, they merged, so we only have one now. And they brought both of their databases together and made one super database. Now, what they do is they provide a way to map all kinds of different exams. It's not just CT, forgive me. It's X-ray, fluoro, it's everything. And you can map, and so you can drill down and you can define naming conventions based on modality and body part. And the best part of this option is it's free. You can go to the website. You can just go to Google, type in RADLEX playbook, and go to the RSNA website, and you can immediately start using it. If you go to their website and you pull up their homepage, you can go in and, for example, I can select my modality, CT, and I can come over here. I can select the region, say abdomen. I can actually get more specific, more granular in my choices. There's a lot of different options. But after I select even just these two options, you can see here, it immediately starts to give you descriptions, and it gives you codes that you can use to group your data. So for example, if you want to do a CT abdomen angio with or without, which could be named really anything, CT abdomen angio with and without IV contrast, etc. If I then go in and I associate this CTA with the RPID code, now irrespective of how I call my CTA on my particular CT scanner, it is associated with this RPID value. And from that, I can then go in and I can associate that across all of my imaging clinics in the hospital. And then nationally, if that is accepted at the DRL level, then whenever someone sends an RPID value number 2 up, the national organization understands that that is a abdomen CTA. And so we don't necessarily have to change the name on your CT scanner. You just need to map it so that it tells what the scanner intention is when it sends the data to the national level. So you can, as I mentioned, you can do everything directly on their website, or you can go on the, I think it's on the left or right side, I can't remember, of the screen. There's this option right here called download, or name download. You can click on it and you have the option to physically download that playbook. It comes down in a CSV file, which could then easily be opened up in any Excel-like software. And when you click on it and launch it, you can then, from your desktop, you can actually you can adjust things. You can narrow down your search, kind of like what I showed in a moment ago. You can do apply filters, and you can look by modality. You can, of course, look by body part. And you can then go through and you can reduce the number of rows of data until you find the exact match that would work best for your data. You can once again identify that RPID value, and you can use that, of course, to map your protocol names at your hospital. My only comment to it, downloading it's great, because if you're pretty flexible or handy using Excel, you can do a lot of work in a short amount of time. But understand that the playbook is an organic living creature. It is constantly being changed. And so if you do download it, you're probably going to want to periodically download a newer version to just compare to make sure nothing has changed. And I say that also with the example that now you set it up, and then say a year from now, you hook up or establish a new hospital at a different part of the country, and they're going to possibly download the playbook. In 1 year's time, those two playbooks could be different. So it's perfectly legitimate to download and use. Just make sure that you keep using the most up-to-date version. You can set up email. You can actually go in and set up email notifications, so it'll let you know when they have new ones. Okay, so once at a national level, you have established that for a CTA of the abdomen, you will use RPID or whatever term you call it, and you establish that. So for CT, you pick your top 10 or whatever 15 protocols. You do the same thing for X-ray, for fluoro, for nukes, for PET, etc. You've now established that you have the nomenclature. You need to give that nomenclature back to the local hospital. And the local hospital will then log into their dose monitoring software, and they need to start mapping things. So this is an example I have here of my Gervais dose and care. On the left-hand side, you can see the national RPID values that's been established for DRL calculations. This is a general fluoro example. So RPID 6820 is used for feeding tube placement. And then what I can do then is I can look at my list of procedures, and obviously now there's going to be a lot more options here. Fluoro NG tube placement, NJ tubes, GJ, G to GJ. I mean, there's a lot of different ways to place a tube, right? In fluoroscopy. And so I do have to use a little bit of common sense as I go through and I map this, and I will go in, I'll select all the procedures that are similar to this feeding tube placement. And once I click on them and map them to this RPID value, from now on, whenever a study such as an NJ tube placement is performed, that dose data is sent to my DMS software. That DMS software collects that data, and now everything is ready for me to push go and send nationally for my DRL calculations. Now, it works. It's all good when it works smoothly, and it pretty much does for CT and for most general fluoro procedures, even some X-ray. But when you get into some procedures such as, or exam types such as your fluoroscopy guided interventional systems, your FGIs, the known nomenclature at the national level doesn't always line up with your local procedure descriptions. As an example, you have abdomen of the aorta, but then you have on the other side, you have like an ERCP, for example, or possibly an esophagram. And being able to link these up can be sometimes very difficult. So I want to give you just an example of how I approach this, specifically for interventional fluoroscopy. In this case, what I had to do is I needed to take a step back and understand my own procedures. So I took the data and I grouped it by radiation output. I created initially just 3 very large or gross buckets: low, medium, and high. And I went in and I initially just placed the procedures that I knew had relatively low dose. And then I did the same thing for medium and high. And I ran the statistics, and you can see them plotted up here in the upper right-hand corner. And you can see once I go in and calculate my statistics that they'll be statistically significant. or statistically significantly different, which means that I've done a pretty good job separating the low from the medium from the high. Now, had I, for example, included, say, embolization, which is a known high procedure, accidentally in one of my low category, what would have happened is this low category would have overlapped significantly with high, and I would have known statistically they wouldn't have been different, and then I would have had to keep organizing. So once I get my three categories, my three buckets, fairly well organized, so I know that they're statistically different from each other, I can then go back into each of these groups, and now I can start doing more refined grouping and assigning those to the RPID. So now I can set up all my embolizations as one, and I can define an RPID, where I can do over here on the left side just my pick placements, etc. Those are going to be low dose, and those can be a different RPID. So the point is here is the dose monitoring software really is a phenomenal tool at being able to bring in all your data from all of your imaging modalities and do some grouping, and then you can from there categorize or assign the the procedure name at your hospital with the procedure name at the DRL or national level, so that you can then submit your data to participate in the next phase, which is data collection. So you've set up a central repository at a national level. You need to set up a way to get the data from the local to the national, either through a DMS or through that paper survey example I gave you. Now, when you go to set this up, you will want to have at a minimum about 20 to 30 facilities to establish your first round of national DRL values. The goal, however, is to eventually get 30 to 50% of all imaging centers in the nation to participate. So 20 to 30 is a great way to start to work out all of the difficulties, work out the things that aren't working properly. And then once you've smoothed the process and got a pretty good working guideline, you can then go and you can bring in more and more and more clinics and working your goal way up to a goal of 30 to 50%. And then, as always, I just put this here to remind you, make sure you are collecting information from a wide variety and types of different imaging institutions. All right, so now that you've collected this dose data, you're calculating DRL, but you need to account for patient size when you're doing dose DRL calculations for the body, so chest, abdomen, pelvis, and age, generally for your head protocols. I give this example on the left. So this is a head CT. So these are just the head CTs from my clinic. And here I've overlaid this red purple colored vertical dashed line. This is the DRL. My median shown here in blue, and this is my third quartile, my 75th percentile of my data. And so you can see here the majority of my data is below the DRL, which is a good thing. There's a few patients that exceed it. That's something for me to look at on a quality control basis. But what I did here now is I actually showed you the breakdown, the demographic breakdown of our patient protocols. So for a head protocol, we basically have 4 exam types, 0 to half year to 2 years, 2 to 6 years, and anyone over 6 years. And when I actually when I break the distribution down here and I actually stratify it by patient age, you see now that the DRL really only applies in this case to my adult head or my adult like heads. In fact, if I were to apply this DRL value to my half year to 2-year-old, this dark blue, they are all under the DRL. In other words, the DRL doesn't help me understand really statistically how well I'm doing for that patient demographic. And this is meant to show you that you need to stratify your data based on patient demographics. So in this case, I really need 2, 3 DRLs and we do have them. I'm only just showing you the one, but you do need to set them up for multiple. Because if I set up a DRL for my 2 to 6-year-old, that was more along the lines of about 500-600, DLP of 5 to 600, you can see that some of those exams are actually too high for that patient population. All right, so we've collected the data. Now we need to do quality assessment. So we have collected the data, we've categorized it, and we've set it up, grouped it by technology. We've grouped it by clinical indications, so a head versus a body, obviously two different doses. And then also screening CTs for lung cancer versus routine high resolution or inspiration expiration type imaging, all different doses. So we have to set up the different clinical indications along with the different types of scanners. And we need to do statistical review. We need to look for the outlier data, make sure there's no one institution, no one protocol that's really skewing the data. And then we need to apply the calculation of at least 20 to 30 studies per exam from about 20 to 30 institutions. So when you do the math, that really breaks down to somewhere in the range of 400 to 1,000 studies per exam type per modality. And that is how we can start to calculate DRL. All right. Now then, at the national level, we've established the DRLs, but that's not the end. That's not conclusion. We now need to take those DRLs, the data, and we need to give it back to the local institution. And once we have it back at our local institution, we can compare our numbers that we're imaging, our patients we're imaging every day, and we can compare them to these DRLs. And then we can start to look at which protocols are maybe too high, which CT scanners or X-ray scanners are too high, and we can start to apply QC. So how do we do this? Well, this is where the dose monitoring software really helps. Where once I receive the DRL values, I can go into my software and I can enter them in so that my software will send me alerts when a patient exam exceeds the limits. So Dr. Canal, she wrote 2 seminal papers over the last couple of years, and she helped develop the national DRLs for our adult NCT for adults and for pediatric. So for me, I can go in, I can take these 2 publications and I can look up the values, and I can go in and I can stratify them. So I can go in, say for head CT, for age 0 to 2, and then I can click on, or if it's BMI or weight or whatever patient demographic you want to use to set up your alert. And then you can click on the different conditions and you can set the DLP value, the volume CTDI, the SSD, etc. So you can enter in all the information from the DRLs into your software so that it will help you understand when something's happening. And I give you an example here. This is once again that data that I showed you from my head CTs. On the right-hand side here, I give you just 3 categories, 0 to 2, 2 to 6, and greater than 6-year-olds. I set up 2 alerts. So this is just personally how I did it. You don't have to do 2 levels. But I set up a level 1. This is based solely on my institution data. So if I want to set my doses really low or really high, I can set my alert levels based on my known population. And then I, of course, used the DRLs. So we got the 75th percentile, which is the DRL, or the 50th percentile, which is the AD value. Now, when I looked at the national DRL values, it turns out that all of my doses were always lower than the DRL. So to use a DRL as an alert level did not make any sense. It wouldn't help me for QC purposes. So in this example, I chose to use those achievable doses, that 50th percentile. I entered those values into my software, and I just give you those examples, those values here. And so for the majority of the time, on average, I don't have any problems, but there's always that occasional study that happens. Something went wrong, the patient had to be repeated, or the patient was just a very big patient, in which case it will usually exceed my alert 1 or the achievable dose, which is set for the national levels. And once we have that information and your software is able to give you that feedback, that is what drives cyclical data-driven improvement. And I give you this example. It's a great example from the UK. In 1980, they established their first DRLs, and over that time period, they were able to reduce nationally their doses by 50%. A few years later, of course, now that you've got the national dose average come down, you need to recalculate your DRLs. And they did that about 15 years later in 1995. They did the process again, and they reduced their doses yet again 20 more percent. And this goes to show you that through systematic approach of making sure that the local hospitals are using doses that are in line with the national average, it helped to reduce those institutions that maybe were using higher doses, but that were not giving any additional clinical, that extra dose wasn't giving any additional clinical value. And so this cyclical process has been shown time and time again from country to country. There's publications across the Southern Asia and Asian continent, Europe, here in the USA, Africa, South America, everywhere that has published these DRLs have shown this cyclical data-driven process is really good at keeping the doses at a reasonable level for our diagnostic tasks. So just in summary, I want to quickly review what we've talked about using the dose monitoring softwares to establish DRLs. It really provides a rapid access for us to collect our patient data and get that data to the national level. We can use this to collect, sort the protocols, the modalities, the equipment type, the patient demographics. It is able to do this. Once you've set it up, it does it all for you. It helps us to establish these national consensus standards, and it helps us to map the standardized protocol names that the DRL committee establishes. And then once we have a national DRLs established, as I demonstrated in the previous slide, it begins the process of appropriate QC for our local institution to make sure we're in line nationally with other like institutions. So I'm grateful for your attention. I'm grateful for the time that you spend at your local hospitals working to image your patients and to do it with the right dose, with the right image quality. If you have any questions, I'm glad to take them now. But if not, I have my email here listed. I'm always available if you'd like to reach out to me. So thank you.
Thank you so much, Professor Brady. Yeah. I'm very excited having your informative lecture. Yes, I have several questions. Okay.
Mm-hmm.
But first, in Japan now, all hospitals have to set up a committee for management of radiation exposure. That is mandatory. Yeah, and that is decided by Japanese law. So almost all big hospitals have to buy those monitoring softwares. Yeah, and that cost high. Yeah, but we can get some amount of reimbursement. Yeah, for that. So I think you know that there are so many CT equipments modalities in Japan, and almost all medical, most of radiation exposure to patient is by CT, I think.
Yeah.
And
Yes.
also, recently, photon count CT like that, the new CT and updated CT can reduce radiation exposure. So, and to reduce radiation exposure, I think the best way is to buy new CT, I think. Yeah. Yeah. Then my question is there any possibility to apply AI, artificial intelligence for management a protocol name like that? Yeah.
That's a great question. Yes, there are some of the dose monitoring softwares that are beginning to implement AI. So the more you take the time to map, CTA abdomen, and you name it whatever that code is, as you do this, the system starts to recognize, okay, there's CTA abdomen with, there's CT abdomen without, there's 2-phase, there's 3-phase, and there's a lot of different options that the scanner may send to the software, but the software recognizes, oh, those are all the same thing. It's not universal yet, but they are improving, and they're starting. Just obviously with AI, everything is starting to become a little bit more streamlined. In the ACR here in the US, at the national level, they are also starting to use AI. So once the information comes up, it can then start to group the data, even if the institution mislabeled the RP ID value, it will still recognize that, no, this is actually a CT abdomen, a CTA abdomen. It's not a routine abdomen. And so there is opportunity to build the AI at the national level. That, of course, just requires lots of information. As anyone knows that has used AI, you need a huge training data set for it to get better and better. We obviously know radiologists more and more for the speech dictation and whatnot is being used in the report generation. And so that same technology is now being used for the dose monitoring and establishing these types of grouping and sorting techniques.
Thank you. Yeah. So I have a question by chat. For the country that don't have enough budget to buy the software and also shortage of medical physicists, any suggestion?
Yes, I would love to come visit your country. No, just kidding. There are, as I mentioned, there is one option online. It's called the Open REM. That's a great way if the different hospitals have the ability to network and connect between institutions. But even at a more remote and even more fundamental basis, if you don't have that, like I said, I showed the manual technique, sending spreadsheets or even physical paper surveys, you can send those. Most hospitals, as you mentioned, like in Japan, they kind of mandate that there's someone in charge of quality control. And it might not be a physicist, it might be a radiologist, it might be a technologist, and that's good. We need to start with what that hospital has. The other thing you can do on a national level is an individual hospital may not have the resources, but maybe at a national level, they can send people. You can have maybe a group of technologists or physicists that can then visit these sites and help establish and set the process up. And once the process is running, they can hopefully train someone locally.
Oh,
Oh, looks like
okay, now you're online.
we're back. But yeah, there's a lot of different ways to do it. Don't let technology be the limiting factor. Even if you're just using paper and pencil, that is better than nothing. It takes more work, but it can be done.
Thank you. Okay, and I have another question by chat. How can you get hospitals and programs in the USA sharing the data for DRL?
So it's optional here in the US. You do not need to send data from my local hospital to the national level. The benefit that we have established is that if you send your data nationally, the national information will then create a report and send it back to you. And so they tried to incentivize all of the hospitals to participate. On top of that, in our country, we have accrediting agencies. So if your hospital wants to be accredited so that it can receive reimbursement and all of those other things to stay open, you need to participate at some level in dose quality control. Now, that may be different across every country. Some countries, obviously have universal health systems, so there's no, the billing is a different process. But every hospital usually has some kind of accrediting or regulatory body that oversees that. And so at a national level, if you're able to either create a law or a policy at that national level saying that they need to participate at some level at quality control for patient safety, then this can become an incentive for them to then participate by sending data and getting that data back.
Okay. Okay. Yes, thank you so much. It is almost time. So, would like to close today's webinar. Yeah. Yeah, thank you, Professor Brady. Thank you again. Thank you.
Yes. Thank you.
Okay.
Oh, that went well. Thank you. I appreciate the
Yeah,
invitation.
thank you. Now, are we offline? Not yet. Okay, and yep. And now you can see a QR code here. Yeah, yeah. Please feedback us. Thank you.